California Healthcare Foundation has been an excellent partner and inspiration to NCQA over the years. Dr. Hernandez and her team are engaged every day in finding effective public policy solutions that improve health across the state. Prior to joining CHCF, Sandra was CEO of the San Francisco Foundation. She also served as Director of Public Health for the City and County of San Francisco. So she's here to share her reflections on California's health equity journey. Please help me in welcoming Dr. Sandra Hernandez.
Well, good morning, everybody. Those of you who are not from California, welcome to California. I was worried you're going to need umbrellas, but you didn't. I wanted to pick up on a theme that Peggy's remarks touched on, and that really has to do with leadership. Because at every level throughout the state of California, there are leaders who have put together this notion that you don't have quality without equity. And perhaps even more importantly, the healthcare system will never deliver on equity if it doesn't address its fundamental racist structures. And I talk about that as a leadership point in part because about 10 years ago, we had a board member at the California Healthcare Foundation who at a board meeting said, gee, you guys know a whole lot about health policy. You know how Medi-Cal enrollment works. You know how waivers work. Like, when do you actually talk to people that we are trying to serve? And I said at the time, and my team who's here will remember this conversation, well, that's not a muscle we have. And he said, well, that's a muscle you should build. And so since that time, we've added to our policy expertise, if you will, to really bring in a first voice. And over the last 5 years, we have asked Californians, what are their top health policy issues? What are their principal concerns? And in our last survey, which we just completed a month or so ago, we asked this question about how well is California doing on addressing racial equity in our healthcare system? I thought it was a good question. We were just having this conversation over here. Those of us who work in it every day might rank it a little lower. About 43% of Californians said we were doing an okay job or a pretty good job. But if you break that down by race and ethnicity, Latinos and our Black respondents had much lower ratings, right? Shouldn't be surprising. But it does give us a benchmark. It does give us a place by which we can say, are we making progress there? And so one of the things that we have added to the tools of work that we've done, in any case, one of the tools that we have built has been to actually build First Voice into all of the work that we do at the California Healthcare Foundation. And 10 years ago, we decided that if we were going to really change healthcare in California, we needed to focus on the largest public program that exists in the state outside and in the country outside of Medicare and the VA, and that would be our Medicaid program in California, Medi-Cal. And so this is us, we're an independent foundation, and we chose to focus on Medi-Cal because we felt like that was the tool by which, if we could make healthcare work there, it would work for everybody. Next slide, please. So some 30 years, we have been working to make sure that everybody in California would have access to an insurance card. And this universal coverage work kind of came to full fruition after 30 years when I was Director of Health, City and County of San Francisco. The largest percentage of our population at any of our hospitals at any time were uninsured or on Medi-Cal. And today there is nobody, regardless of immigration status in the state of California, that is not entitled to enroll on Medi-Cal or Covered California or have commercial insurance. It's truly, it really is incredible. And yet, we also know that although you might be entitled for coverage, actually getting enrolled in coverage is in itself a structural enigma that people have to struggle to try to get through. Many people working on this, including, of course, stopping to say, you're going to give me a clicker? Okay, thank you. That's my last slide, so it doesn't matter. So we have been doing focus groups with folks to try to understand how people fall through the gaps on eligibility. And of course, you know the public health emergency post-COVID is over. We're in the midst of a large redetermination effort. And so to really understand up close, we've been working very closely with the Department of Healthcare Services, who, by the way, administrative leadership, visionary leadership, really the first time when there has been an administration in 35 years that I've worked in this space, that the entire administration is working hand in hand with consumers and beneficiaries to solve these problems. So let me just acknowledge DHCS and their team who are here today, because it's extraordinary. But you can't fill the gaps and people falling through redetermination if you don't actually sit and find out why people fell through the gaps. And that really is the whole point around how we think about reaching health equity. There are cultural issues, there are institutional issues, and then there are very specific issues that relate to particular populations. So universal coverage, we have eligibility, now we have to get access. Once everybody has access, they have an insurance card. Then the question goes, okay, well, does that actually get you into care? One of our team members who's in the audience, I think this morning, sponsored a secret shopping survey. We asked RAND to look and see if you were a non-English speaker and you were diagnosed with depression, how would you be able to access the delivery system to achieve the treatment prescription for your depression? They called people in English and in Spanish, and they called a variety of delivery systems to try to understand what that would be like. It won't surprise you to know that if you were a Spanish-speaking person and you were trying to get access to behavioral health through all the places that we called through this RAND survey, you were on the phone waiting 10 minutes for an interpreter. You got disconnected. You got sent to another place where nobody could answer it. Or they would just say, we don't speak Spanish. Sorry, can't help you. Right? So as important as coverage is, and as long and hard as we have fought towards that, having coverage alone does not guarantee access. So work yet to be done there. The administration under Secretary Galley had a very bold vision, as did the governor, that it was really time to take our social service delivery system, our healthcare delivery system, our housing delivery system, and really a once-in-a-generation opportunity to transform our Medicaid program through what we refer to as CalAIM. Bold, extremely challenging. We're taking multiple systems and trying to weave them together with the focus on folks who have had the most difficulty and the least opportunity to access coordinated, integrated, dignified, whole person care. An extraordinarily bold initiative. You're in California, I don't know what other states you come from, but we have a very significant population who are unsheltered in the state. And a large effort of CalAIM is really to try to figure out how we get people who are unsheltered the care they need, as well as the navigation into the systems of care that will allow them to stay sheltered and get the care they need for what are typically multiple chronic conditions, behavioral health, substance use disorder, untreated chronic conditions, and the like. CalAIM is built on, California's 40 million people, it's a big state, we're incredibly diverse, but it was built on some very thoughtful designs around system change, which was very much focused on whole person care. And in California, we started with the willing. So counties raised their hands and said, we're willing to try to take on and pilot whole person care, some targeting reentry populations, some targeting unsheltered populations. And CalAIM essentially built off of what Peggy described as our learnings. What did we learn from whole person care? Was there a way to scale that in a state that has large rural populations, large urban populations? And so CalAIM now has this incredible challenge of taking health plans to work with organizations that do housing navigation, or that provide social services, or that provide food programs. So imagine a nonprofit who provides that service in a social service arrangement over many years, now trying to figure out how to work with the health plan, how to provide contracts, how to do claims management, how to do data exchange. And so CalAIM, we're about 2 years, depending on your count, 2 or 3 years in the waiver process. All of it built on learning, as Peggy identified. And really, if people were to ask today, well, how well it's going, we actually wrote a paper about this on our website, and a reporter picked up the story and sort of wrote the glass is half empty, really hard, not working here, in spite of the fact that the story was there's many places where it's working really well. And actually, both are true. Both are fundamentally true. So we have a lot of populations that, if CalAIM reaches its fullest potential, will unequivocally improve the lives of many folks whose opportunity at healthcare, in spite of having a Medi-Cal card, have really not met the expectations that we have for quality and for health outcomes. Before Governor Newsom became Governor Newsom, we anticipated a new administration coming in, and the sister foundations got together and said, all of us are working on the margins with regard to workforce. California Endowment, the Blue Shield Foundation, the California Healthcare Foundation, we were all dabbling. We decided that we would seat a comprehensive commission to ask the question, what does the healthcare workforce of the future need to look like in California? We commissioned that. We had a corporate sponsor, we had an academic sponsor, focused on primary care, focused on aging, and focused on our behavioral health workforce. With the large recommendation that the incoming administration would set up a vehicle by which we would deeply invest in very, very intensely designed workforce programs that would meet the needs that we had identified through the commission. And I will say, and the evidence will bear this out, a lot of what we need to be able to do to realize actual health outcomes is to build comprehensive, coordinated primary care teams that engage and involve and compensate and train promotores and community health workers and people who speak the language and are well trusted in their communities. Doulas, another workforce that we wanted to be able to identify in our workforce in primary care. Governor came in, he set up an entire new office, the Office of Healthcare Access, created an entire workforce enterprise where we're actually measuring the way in which we are pushing people out into a workforce that is more culturally diverse, that represents the diversity of our great state, and that allows us to really tap the knowledge that is inherent in communities that will help us reach meaningful health outcomes. And so workforce is an area that we continue to work with the administration on. The largest investment in the history of the state on healthcare workforce has been put forth by this administration. Getting people through those pipelines, COVID taught us a lot of things, including a lot of things that we can now do through telehealth and telemedicine. That too, we tried that during COVID. We learned from it. We said, where does it work well? And now really trying to assess what is the usefulness around telehealth in a lot of different areas of care, but particularly in behavioral health. And none of that can you do if you don't actually recognize that the system that we started with and that we're trying to integrate and coordinate, at the same time, you need to actually actively dismantle the inherent racism that exists in that system. That work has, for us, started with a large survey that we did called Listening to Black Californians. An incredibly powerful survey. It was conducted by a group here in LA. And they went and did focus groups and large surveys to really hear what the experience was of Black Californians, whether you were in Medi-Cal or in a commercial insurance or Kaiser or whatever plan you might be in. And it won't surprise you to know that their experiences were completely reflective of long-standing racist policies that exist in all of our systems, in our education system, in our housing system, and in our healthcare system. And so all of this work that we're doing, whether it's on coverage, whether it's on workforce, whether it's on transforming the delivery system, in order to actually meet people where they are, give them whole person, dignified care, you have to actively acknowledge, A, that racism exists in our system, and that those policies and procedures need to be named, and that there need to be very specific interventions to address them. And the work that we've done in listening to Black Californians, I reflect back to Mark Jones, who was on our board, saying you have to actually listen to understand exactly what it is you're trying to solve to. It's not an abstract idea. And part of that realization is that there does need to be advocacy and voice from within the Black community in order for us to take down these policies and to change the kinds of outcomes that we want. And last and not least, we're at an NCQA event. A partner of ours has done work with us. None of what we're trying to do in CalAIM, in coverage, in workforce, in our health equity work is going to happen if we're not actually meaningfully able to take data, individual data that's understood by race and ethnicity and gender and sexual orientation, and be able to actually look at populations and understand how those outcomes are changing over time and what the systems and barriers are that remain to be addressed. There is now in California, and in many ways the least sexy, but in my mind some of the most important work that we're doing was to build a data framework by which we're going to share in real time data at an individual level, at a community level, at a population level. If you think about the pandemic, so much of the friction that we had in doing the services that we were trying to do during the pandemic were limited by the fact that the counties and the health plans and the docs really didn't have the ability in real time to share meaningful data. There is now, as of January of 2024, a requirement, a framework to participate in data sharing. And again, at the center of that needs to be the consumer and the patient that we're dealing with. In California, essentially what we're trying to do is make this a person-centered, whole-person delivery system that actively and every day tries to take down the systems and policies for which we have lived for many, many years in order to bring first voice, problem-solving, advocacy, coordinated, and integrated efforts at addressing these entire set of issues. I would say that California is on an amazing journey. You can't do the work that we do if you don't fundamentally believe you're making changes and change is possible, and that you have to be able to measure that which is changing. And so I want to congratulate Peggy and her team on this inaugural forum on health equity. California does a lot of things really well, and we learn from other states as well. And so I want to encourage those of you who are not from California to ask us the hard questions while you're here over the next 2 days. And I guarantee you, you're doing things that will help us on our long journey towards health equity. So Peggy, thank you to you and your team. Congratulations. And I hope everybody has a good conference. Thank you.